So thanks, Theo. This is great. This is the first time I've been to Berlin, so this is really exciting. As Theo said, we go back a while. I've been here since the beginning of UX Healthcare, more or less. So it's a pleasure to be back in person again. And today I'm talking about a project that I led with Nuom around service design, helping to eliminate hepatitis C. So I'll just introduce who I am. I'm an associate consultant at Nuom, also a non-exec director. Nuom is a growing product and service design agency that specialises in health tech in the UK. So it's great that we're here in Europe to sort of spread the good work that we've been doing. So I'm just going to set some context first. I didn't know anything about hepatitis C before I started this project, so I'm not going to assume you do. Probably a lot of you do know about hepatitis C, but it's a blood-borne virus that affects the liver. It can be life-threatening if not treated. Treatment has improved over the years, but that doesn't mean to say that it's curable, because there is no effective vaccine as of yet. So it's actually a lot more serious than people realise. As of 2019, there were 118,000 chronic cases of Hep C in the UK. And the World Health Organization is looking to eliminate it globally by 2030, which is an ambitious target. Egypt, for example, the picture on the screen, they had very high prevalence of hepatitis, and the government has just gone all out to eradicate it, and they're on track to eradicate it by 2030, which is excellent news. Similarly, in England, and I stress England, not the UK, this is England, right? So this is applicable, I think, to anywhere, but I'm going to talk about this project we ran was NHS England. They're targeting 2025. Now, the NHS, to put it mildly, is, I wouldn't say quite on its knees, but it's having a hard time at the moment. So the fact that England and the NHS England is aiming to eliminate this by 2025 is a really, really positive target. And actually, as I'll demonstrate, we're kind of on track for that, which is great. Part of that key component of elimination is to provide a home self-testing kit to screen people for the virus, which just hasn't been available. The touch points for screening and testing have been very specific and not widely broadcast. So the way that we came into this was NHS created a brief and awarded this to Preventex. Now, Preventex are the organisation that conduct the testing operation. Preventex approached Nuom to run the discovery and alpha phases, and I'll explain what that is just in a minute. Partnered with the Hepatitis C Trust, who act as the subject matter experts for hepatitis C, and they know everything about hepatitis C, which is great, hence the name. So given it's a population level problem, we had 10 weeks to get into development of the portal, which was challenging and fun. So I'm going to use the double diamond analogy because it's helpful and most people know what the double diamond is. So we kicked off the project 25th of October to basically do our research. Now, from Nuom, that was predominantly me as lead design consultant, also wearing a user researcher hat, also wearing a service designer hat, and my colleague Patri, who should take as much credit as anyone who sat there towards the back as the product manager. So this was rapid, and actually, Bert talked about research ops. Our research ops was done on the train in an afternoon. It was just like, right, get a discussion guide out, get the Hepatitis C Trust to try and recruit as many relevant risk groups. We'll talk about risk groups in a minute. So it was rapid. That's good because it's focusing, right? And then we did that. We cast the net as wide as we could in the time we had. We narrowed that down to prioritization. A month later, we kicked off the design team. That involved another couple of people from Nuom getting involved, very talented interaction designer called Madeline and a copywriter called Becky. There's much more collaboration going on at that time with Preventex and their team as they were starting to see what was unfolding, what they were going to need to develop and put into beta. And then beta kicked off at the 3rd of Jan, just as we were being service assessed by the NHS, which then ran through to a live date of the 13th of May. Now, In the UK, being a government project or being a government agency project, this needs to be accountable to service standards. Now, GDS, Government Digital Services, have come up in the last 10 years or so, have come up with a set of service standards by which all government services, which have improved rapidly over time, are assessed by. So it's like going back to school, and I used to hate exams, but on the beginning of January, we had a big exam to make sure that we had run this discovery and alpha phase properly, which we passed, which was good. But that was quite scary because discovery alpha beta is a sort of recognized methodology by which sort of you get a pass, you kind of get a pass to go through, and in many cases you get recommendations. Sometimes budgets aren't even given, so it was quite a big deal. So our approach had to be nailed on because we had 10 weeks to get to beta. And when it went live, it was headline news on the BBC, which I don't think I've ever had before in my whole career. I've never been able to say my work was on the BBC homepage, which was brilliant. I was really chuffed about that. I was shouting about it, and I was telling everyone else that they should be chuffed about it too. So let's talk about the discovery. The problem statement that we sort of looked at was mainly around, as I mentioned before, with a lack of sort of common testing. Where were those unmet needs in terms of hard to reach people? What were their understanding of hepatitis C? What digital access needs did they have? We were basically trying to say, if somebody who isn't going to a clinic or isn't doing sexual health testing typically, how are they going to get access to a testing service that they can do discreetly and they can therefore get into a patient pathway? So that was our primary problem statement. And the risk groups we were targeting, I mean, anyone can get hepatitis C, but the risk groups that we were targeting were people who inject drugs, the South Asian community, people that had had blood transfusions prior to 1991. There's an ongoing inquiry into that still. And the fourth group was gay, bisexual, and men who have sex with men. So they were our primary risk groups, but I stress that it's open to everyone. And the hypothesis is based on the problem statement, really. It's just to learn to the extent to which a cohort of HEV risk groups might become aware of hepatitis C, and then enough for them to take the action to then go and get tested for it. So, what did we do? We had very little time to do as much contextual inquiry as possible. And I've heard several references in the talks previously to qualitative research. And this is brilliant. Like we split our time between remote interviews and focus groups on site. Two key ones were we went to Leicester to a drug and alcohol rehabilitation centre, where in an hour I probably got more useful information than I could have got with a month of doing statistical quant stuff. It was absolutely fantastic, absolutely brilliant. And then I did the same sort of thing, went to Bradford, where we spoke to a broad range of Pakistan community that represented South Asian. Again, that was hugely beneficial. I think the key thing here, though, is before we set up these end user, I'm not going to say patients because not everyone's a patient, before we set up these end user groups, it was hugely valuable to use service providers as a proxy to not only get access to representative users, which is a huge benefit for research ops, actually. Just when you're time poor, that sort of proxy, I'm a healthcare expert, I know I can get you in touch with people. But it was also really helped to sort of nail down that our hypothesis was right and that we were contacting the right people and we were framing our discussion guides in the right way. So that sort of step, so the service provider forum was a great sort of conduit to then go and speak to people live, end users. And our research themes broadly came down into these 6 areas. I'm not going to go into all the detail because it would take too long, but what I'm going to do is I'm going to run through each of these themes and just play back a quote that sort of summarized what we found in relation to these themes. So first of all, one of our probably less risky assumptions was that there was generally low awareness of hepatitis, which was true. But what was interesting is where we thought the stigma, the social stigma, would be associated, wasn't right in our sample, within the remits of our sample. So, for example, we went in with an assumption that South Asian community, there is a high level of stigma associated with hepatitis C. Actually, what we found was that there wasn't a particularly high level of stigma. There was just no awareness. In fact, we had a group with, we had a mother and a teenage son, and based on what we were told, it was like you would never get that conversation happening within a family. But actually, they were openly talking about, well, yeah, I mean, if I had, like a typical use case here is where people go back to see extended family in Pakistan and they decide to have cheaper dental treatment or medical treatment, and they often then come back and they can often contract it that way. People were like, well, if that's going to happen, I want to know, and this is something that I should be aware of. So that was a risky assumption that was invalidated. However, conversely to that, in the PWID, the people who inject drugs session, it was very much felt that there was a high level of sensitivity towards society has a legacy impression that hepatitis C is relating to an unhealthy lifestyle because it's liver related. They think that you drink too much, or it's associated with heavy drinking, and because of the drug use context for which these people are in, they did feel stigmatized and they did feel much less comfortable and required more anonymity relating to even talking about hepatitis C, let alone being tested for it. And so the top quote there is interesting because the older generation who were affected by blood transfusions also had memories of times when treatments 20 years ago or more were horrendous, like just pretty horrible. And actually hence I'd rather have cancer. I mean, to say that is quite extreme. So that was another sort of assumption that was lingering around the extent to which I don't even want to know if I've got it because the treatment's bad. So then trust in medical authority, I'll go on to explain how this was one of the best assumptions that we invalidated, but just trusting the service and where it came from came overwhelmingly strong in terms of the NHS knows who I am. They'll probably have a record on me. I need to interact with the NHS. Normalization, there was an advantage in the timing of running this because it was post-COVID, so people had got used to that sort of, I'll test for COVID. It's really, really simple. The process isn't as simple because you need to, there's an exchange of blood and there's a testing and there's more of a process to it. But the fact that people thought that if they're going to get tested, it needs to feel normalized. You need to take the risk groups, you need to downplay the risk groups and play up the fact that actually testing for hepatitis C is a normalized thing, that it can be universally accepted as something that anyone would do. Anonymity and discretion, again, I've sort of made this point, but the extent to which people really needed to make sure that they weren't going to give any unnecessary data and who was going to have access to that data. And the UK HSA was very keen to get a lot of data. So there was a tricky balance. You got a sort of a governing stake of governing regulator saying, give us all the data you can. And then you've got this evidence saying, yeah, but users don't really want to give you that data. They didn't with COVID, so why should they with this sort of thing? And then treatment reassurance, especially given the sort of incorrect information around what happens if I am tested positive. People wanted to have human contact. Some people wanted to be anonymous and to have text messages, but really human contact, if going into that positive treatment pathway, was important. And almost overwhelmingly, everyone said that they would make this a mobile-first experience. Nobody said I'd do this on a desk. Some people might do it as well on a laptop or an iPad, but overwhelmingly it had to be mobile-first, which was really useful because it was just like, well, don't even bother with sort of desktop first. It was mobile-first in its application. So so in terms of unearthing real-world user lead, it was these 7. It was, I need to know what it is. I need to know if I can be treated and how that will happen. And I also need to know, am I going to put other people at risk, which is kind of a secondary one to number 2. I want to know that the testing service is trustworthy and has medical authority. I want the choice of what personal information I submit. I want to be able to speak to someone if I get a positive result, and I need to know what to do, basically. So you couldn't just, and what was really interesting, you couldn't just build an app. There's so many people in healthcare build an app, and they see the journey as that. They don't see the journey as that. They see the journey as that. Let's build an app, and we'll solve all the problems. And it's like we knew that we couldn't take that approach to just that one touch point. It's worth a note on access needs, because especially with the PWID group, there's so many situations that might restrict their ability to get tested at all. This is due to impaired cognition, depending on the stage of their drug use. They've got other life priorities, which are pretty overwhelming. They're also in and out of actual hardware use or even acquisition. And they have a fundamental mistrust, often incited by an extent, a degree of paranoia around digital services that require use of data input. So we had to be really mindful. This is why I go back to that sort of speaking to people in context, because you just don't get that sense. If you've got a room full of 13 people that are giving you this information, you don't really understand what their life's like. Well, you certainly don't within an hour if you're not with them, and we didn't have much time. We spoke to a couple of people with dyslexia. Needless to say, they emphasised the fact that if I'm going to go through this journey, you need to be really clear about what you're saying. Don't give me long pages of text. Don't give me unnecessary amounts of content. So that was hugely invaluable insights. And so we validated or invalidated our riskiest assumptions, one of which I alluded to was the fact that when we went into this, the service provider just assumed that this would be a third-party branded authentication app where people would sign up and they would register and they'd get a dashboard and it would be branded a company which nobody really knew. That would have completely failed. And that was great because we could show through research that the reasons why it had to be NHS branded, the reason why it had to be really open, and nobody had a problem with that. Nobody sort of fought back against that. And I think that speaks to something that has also come up in the last couple of talks, where people have talked about leadership sort of being a blocker. And with this project, I'm old enough to have developed a bit of a superpower around this, but with this project, I just relentlessly shared what I did. And we just kept sharing it with the whole stakeholder group, with the 4 partners, and especially NHS England, and especially the programme lead, who had a lot on his plate. But in sharing and telling a compelling story about what you're doing, bringing to life the research sessions that you're doing, nobody then sort of had a problem with it, really. They just sort of went, okay, well, we thought we would do A, but I can see why we're doing B. And that was just great because everyone got on and everyone didn't sort of throw a spanner in the works, especially when you're time poor. So then between discovery and alpha, we broadened the whole program out to look at service design and started service blueprinting. And the benefit of service blueprinting is that you bring in to the co-design process all the people that are across all the service lines. So I labour that point about building an app. Building an app in isolation was never going to solve this problem, because the key component of this working is when someone receives a positive test, they need to be transitioned into the operational delivery network that the NHS, which is highly devolved, and anecdotally quite inconsistent from region to region. So I'm just going to break down that service blueprint. So on the top swim lane in the grey, we've just got the stages. I mean, I'm sure you're all familiar with service blueprints, but you've got the stages of the journey, right from inception, right from awareness, campaigning, do I even know what hepatitis C is, right the way through to a positive result and treatment. So then the yellow swim lane is the customer touch point, as in a conventional customer experience map, from awareness to treatment. Then you've got the pain points that are associated, just to highlight where you could drop off along that journey. And then you've got the front stage. So these are the people that are dealing with the users as they apply for a kit. The kit gets sent out, they take the blood test, they put it back. Now that's Preventex, that's the test service provider, or test service operator. And then you've got the support layer. So this is the Hepatitis C Trust. They're the people that are manning the helplines. They're the people who are giving advice to the clinical staff in the NHS. which is then the backstage. So then we've got the NHS England coordinating that campaign network across England. And then you've got the good old UK HSA that want all this data to come in so that they can look at trends and see how elimination is on target and all that kind of stuff. So that this was so important to not only make sure that everyone was in agreement with the process that needed to happen, but that there weren't any sort of leadership spanners in the works further down the line that said, oh no, I don't want to do that, or that's not going to work. But so it made sure we looked at the journey end to end. I mentioned the operational activities. Yeah, as I said, they're very devolved, and because there was this overwhelming need of human reassurance, essential that the ODN leads understood what was involved once the test had come back positive and where they needed to pick it up. So they were involved in service design as much as the design team were involved. So that moves us into Alpha. Alpha, the team grew, became more multidisciplinary. There were more developers involved, more product people on the Preventatex end. And so we did the usual things. We've sort of flowed out the IA of the app to make sure that we were triaging it. It was an 18 and over. It had to be UK. There had to be geographical address checks, all that kind of boring stuff, which is really important because it qualifies people in or out of using it. Then we storyboarded all the wireframes as per usual process, and then we ended up with Sprint 1 prototype, which we tested, which was positive, which was great because we'd had such compelling research. We generally got it pretty good first time round, so it tested well. Reassuring and easily understood was something that came out. Well, I've got some quotes here actually to bring to life more. So what was lovely is that because we brought in a copywriter early on, we really saw the benefit of normalizing and simplifying language as much as possible. The reading age plummeted so that we could really understand how we were going to engage with all of these risk groups, some of which do have a very low digital literacy. So we broadly had a situation where people were understanding what the ask was, understanding what the call to action was, but still weren't really sure about whether it was for them or whether they would want to do it. So the things we changed was we needed greater clarity around service name and introduction. So we had to be really explicit. So even though the content actually grew a bit, we had to be super explicit about this is, this can be cured. It's just a course of tablets. It's not going to be hereditary. There were all sorts of comforting and just normalizing language that we went through and we tested rigorously against user groups in the rounds of testing. So we grew the numbers from the initial discovery when we were in alpha, which was great. What else did we do? More reassurance around getting treatment so that people could really understand, well, what are the conditions, what are the symptoms, and if I do need treatment, what will happen? And this was an interesting one, possible transmission route. We made a really silly mistake of just putting this list in an alphabetical order, which is silly because the top of the list is drug paraphernalia. And so anyone that's not someone that's been injecting drugs comes onto this question, which is really important for the UK HSA, really important information, and they go, I've not been using drugs. So it's just a real no-brainer. We tested it, and it was like, well, don't put drug paraphernalia at all. Make it alphabetical, and then it doesn't stigma. It doesn't enforce that stigma that's already enduring that we're trying to eliminate. And surprisingly, on the second round, this actually tested quite well because the trust had built up to the point where people are comfortable with the call to action and they're going through the process of ordering it. They're actually filling this out, and anyone that's not comfortable, they prefer not to say just was found and it was used. So we were encouraged by the fact that this wasn't completely ignored by everyone or wanting to be diverted by everyone. What else did we have? Antibody confusion, what the test was actually doing, that needed to be clarified. Simple UI fails, like putting a box around things and people thinking it was clickable, when actually what you want to do is order a test. So just don't do that, just make it a list. Really, really simple stuff that we should have known, but we didn't do, and you pick it up in testing. Primary navigation order, pretty minor stuff, to be honest, but it was all important stuff because people just weren't sort of navigating around the site when they were using the primary nav. So then that took us into Sprint 2. Sprint 2 is more refinement, but also the opportunity to replicate as an Urdu version. There was enough compelling evidence when we talked to the South Asian community that second generation or older family members would be using this in Urdu, or even if they weren't, they might get a family member to support them using the app in Urdu. And it just seemed like, why would we identify a risk group and then not provide a solution for the people that we've gone and spoke to? So this was great. I mean, I've never done anything in Urdu before. I don't know how this happened, really. Some people that are really good at Figma managed to prototype this, and actually it was, I'm going to skip because I mean this we managed to, with getting volunteers, we managed to get the language accuracy enough to go live with, which was fantastic. And you just can't, you can't do that without a huge amount of time at additional cost. So just through going back to that service provider network, finding people who can help you with research ops and getting access to those user groups is invaluable. Talking to the South Asian community, we were, through the second round of testing, we were aware of how there was particularly low levels of digital literacy. So it's not just the language, it's actually, I wouldn't even do this myself, even though we've made it as useful and as normalized and as sort of inclusive as possible. We had to bear in mind the proxy user of the family member. And that spoke to, well, yeah, but you told us that, you don't talk about this with family members. And it's like, well, actually we do. We're happy to do that, but you need to be aware that I'm going to get someone else to do this, or someone is going to be ordering a kit on someone else's behalf. Good feedback again, particularly the bottom one there. Really good to know that, to let people know it's not interferon. Interferon was the legacy treatment that was sort of pretty horrible, and now I think there was huge comfort across all the risk groups around a course of tablets that it takes several weeks rather than several months. Changes from round 2. There was confusion around mobile and email, whereas actually it was going to be mobile by default. So let's not confuse them by getting to put two points of contact. And I've already talked about the Urdu translation. And then this is it. So it went live in May 13th. I can take you through it. I don't know what time I've got. Maybe if we've got time at the end, but I'd love to talk about the outcomes, because when I first did this talk, it hadn't gone live and now it's gone live. So I'd really like to talk about the outcomes, because that's the important bit, right? So in the 4 months, we got data to the 11th of August. So it's not, there's things will be higher than this. But to the 11th of August, we've got 60% return rate on over 6,000 orders, which is great. We've got nearly a 50-50 split, so the males, which are traditionally low levels, are actually coming up to like 48-52, which is a really good sign, because that's evening it out on the gender. Good spread from 25 to 70 on the age range, and that point around non-English residents, 20% are outside. 20% of results are coming in from outside of the UK, and Pakistan, Poland, and India are the top 3, and that makes up 20% of orders, which is really good. Deprivation decile, this is what I'm most proud of. So there's 10 deprivation deciles, and there's a 10% spread across all of them, which is absolutely fantastic, because that means that the 3 lowest, which have the poorest health outcomes and the highest digital access needs, are equal to the highest decile. So that means that we're reaching the people that we spoke to, putting it really simply. We're not just sort of getting people that are comfortable and have got time and have got lots of access, and that we're managing to reach those hard to reach people. Good uptake from rural communities, surprisingly good uptake from rural communities. So there's a good geographical spread, and as I mentioned before, the route of transmission is being answered. It's not being skipped. So the data coming back is good. The actual test results themselves, the antibody insufficiency is really low, so 90% are coming back usable. The RNA positive rate is 0.75. That doesn't really mean anything, but it's higher than anticipated within the numbers we've got. I mean, I think that's the key takeout there, that the numbers are good, which means that there's more people going into treatment. Of those 6,210 or whatever it was people, there are a high percentage of those going into the treatment pathway through the operational delivery network. We're hitting the hard to reach people. It's normalizing in society, starting to normalize in society. So people that have contracted it through piercings or tattoos or sexual contact somewhere outside the UK, those things are being picked up, and already you can start to tell a story that it's not just people who inject drugs, that it's not just certain risk groups. And it therefore means that the NHS is on track to eliminate hepatitis C by 2025. And it's been put up for an award. So in summary, I think the 6 things that I took away and the team took away is, and I know you've heard this all before, but it's really important to reiterate. So understand the problem before design the solution. Don't go in thinking you know what it is, because this was such a good example of where that would have been a folly. Run research with real users, primary formative research, not secondary research. Contextual inquiry, absolutely invaluable, especially when you're time poor. Validate your assumptions, as they'll never be right, not all of them anyway. Collaborate across all the service lines, so not just with the product guys, not just with the designers, get everyone involved across the whole service line. Hire a copywriter, because content, if you're not thinking about your content, it doesn't matter how good it looks, it's gonna fall, isn't it? It's gonna fall over. And tell a compelling story so that all of stakeholders, all of your leadership understand why you're doing it, and you sell the benefit of user-centered design. You sell it through doing it right. And I think that, you know, taking this approach means that we truly met the needs of the users. And even though I'm talking about a problem that exists globally, but we solved in England, I believe that, you know, designing a solution to a population level problem in this way could apply to any health service in any region, especially at the back. For any user, so please just this is an English case study, but it's applicable to any problem anywhere, in my opinion. And that's it. No questions. No questions.
I had a quick question on copywriters.
Yeah.
And in my experience going through this process, basically never really found the right fit or the right tone, the right degree of understanding of the problem. To what extent, how important is it to brief, or what are the strategies to get the copywriter's head in the game?
From early as possible. So the copywriter wasn't there for the discovery, but ideally she would have been. In GDS world, there's your core team is a user researcher, an interaction designer, and a content designer. They call them content designers because they're a bit more than a copywriter. But the main thing is to have a copywriter. So I pushed really hard for this because there wasn't any provision made for it at all, and it was so obvious from the get-go that this was going to be won or lost on the language used. So I pushed really hard, and we found a copywriter. So she was brilliant because she had a lot of experience in writing for sexual health testing. So it's very analogous to the way that you sort of need to approach this tone and sensitivity and the discretion needed. And honestly, I don't think I've been doing this for over 20 years, this kind of work, and I've never been in a situation where a content person hasn't added huge value. Because if you don't think about your content, what are you doing? You're building a pretty shell, aren't you? You know, it's like you've got to think about content, even if they come in at the design phase and they're briefed quickly and they understand the context. They just add so much value. I suppose my only tips more specifically is to just brief someone that has experience working in a multidisciplinary design team, so that they understand the process, so that they don't sit outside of the realism of a prototype. They understand how to work within a prototype.
So, for instance, they're the ones going out in the alpha stage to the users and sort of iterating their view of what was the best copy that they could come up with, but then really going, okay, that didn't perhaps evolve it based on the feedback that they've got from those stakeholder groups.
So if the user researcher is running the test session, then your designer and your copywriter as a minimum are observing that, and then they're hearing firsthand what word doesn't make sense, how much content was obscuring the key call to act, whatever that nuance is. they're just hearing that firsthand and then they're on it immediately, rather than you having to brief them and then going, okay, well, I'll try something else, and then writing some long form.
It's lost.
It's lost, exactly, it's lost,
First off, thank you. I've loved that story that you told, and to do that in such a short amount of time as well. Big achievement.
We had a good team.
Yeah, no, I can see. I think the question I wanted to ask was this about the service provider forum. In my experience with NHS England, national projects, that can kind of make or break the success of the project sometimes. Was that something the Hep C Trust had set up already, or was it sort of together? And what did your engagement look like?
That's a great question. Yeah, so it was a two-pronged approach. The program lead was brilliant in proactively introducing us to key people at the Department of Health and Social Care and local trusts, in parallel to the Hepatitis C Trust, giving us access to loads of charities that are specifically targeting. In this case, it was sort of mostly around drug use and male sexual health. So we had all of these charities that were very nuanced around, well, I can tell you loads about this risk group, and I can get you access to this risk group. And then you had NHS that was saying, well, let's talk to this local trust around what data we've got on the other risk groups. Maybe, for example, the blood transfusions, because they're not a distinct group that a charity might run against. There is, but not to the extent of the sexual health and the drug testing. So it's a two-pronged approach where, I mean, we just lent on them. We just said, look, we've got to be speaking to end users in a week, so get us access to everyone that will know that the proxy. And we just got on a big call, and it's like a 2-hour workshop where we just nailed our assumptions and our approach to getting access to these people. So it's really effective. But I understand that you need a proactive program manager. But maybe that's a prerequisite on the onboarding. You say you'll need to be a proactive program manager, to solve a problem.
I'm just going to take one last question.
Yeah, sure. Sorry.
Sorry, I'm very impressed by your presenting. If I could give you an award, I would give you right now.
Well, thank you very much.
So I didn't really get that question, but I was just wondering, so what is your strategy right now to find all these potential
Hepatitis C, yeah.
Now so these cases, these potential, what's your approach to finding them or them finding you?
I'll be honest, that's not up to me now. That's a job purely for the NHS, because they have an ongoing campaign to understand that this testing service is continuing to reach. So homeless people are another big area, really big blind spot. They're synonymous with people who inject drugs. So there's a huge campaign going on around homelessness. That's not something that we're directly doing, but what it is happening is a lot of the partner charities that we talked to at the beginning, they are actively involved in campaigning those risk groups. And that's World Hepatitis C Day was a couple of weeks ago, and there was a massive surge in orders. So it's obviously working, but I'm not close to the campaign plan running up to 25. We do keep in touch with them regularly, and all I know is it's going well. The orders are coming in, so that's a woolly answer. Sorry.
So thank you very much. Can we just have one last round?